Hello and welcome everyone to this session on Anesthesia Revision Part 1. My name is Dr. Jhanvi. I am the Anesthesia Educator on Unacademy. I hope that all of you are able to see me and hear me well. If the streaming is okay, please leave a thumbs up in the chat box. Yes, I can see that the streaming is absolutely fine and we can begin with our lecture for today. So today we are going to be revising the entire anesthesia in 2 sessions for all of you who are going to give the NEET PG exam. This is a wonderful revision session and I encourage you to be a part of it by answering all the questions that I ask. My name is Jhanvii Bajaj. I am an MBBS MD DNB in anesthesiology. And this is the Telegram channel where we post the links to all of our classes. So I want all of you to make sure you join this Telegram channel, Let's Crack NEET PG, so that you are able to get the links and the updates about all the free classes that will be held. The All India mock test is on 26th of February at 9 a.m. and I urge all of you to participate in it. This is not only going to give you a bunch of practice questions, but it will also help you identify what is your ranking amongst your peers, where are the mistakes that you're making, and it will help you get a better rank in the main exam. Now, the Plus subscription on Unacademy will give you access to both live and recorded classes. You can learn from India's top educators, you can compete in live tests and quizzes, you can study on the device of your choice. The Iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the video lectures of PrepLadder, which are already recorded, along with the live lectures of Unacademy. Also, you will get the question bank of PrepLadder, which is something that everyone loves, and the rapid revision and dream notes of PrepLadder. These are our FMG December toppers. We also have the educator curated test series, and in this we have individual tests which are carried out by the subject wise educators. And if you would like to try the Unacademy platform, you can come on to the special classes. Here we have interactive live classes, polls, raise a hand option, and lecture notes at the end of the class. Now these are all the batches that are going on right now in Plus. So we have the All Educator Revision batch for the NEET exam. We have the Target Next 2023 batch. So you can see I'm a part of this batch. It will be starting from tomorrow. And we have the Focus FMG comprehensive batch for now and for December. So if you would like to join the Plus subscription, you can use my code Dr. Jhanvi Live, with which you guys can get 10% off on your subscription value. And remember, if you buy the 1-year subscription now, we have a new offer running that you will get free notes along with it. So if anyone wants free notes along with the Plus subscription, this is the right time to buy your subscription. Alright, so beginning with our first class for today, this is a series of images that I have for you guys. Now I want you guys to identify each and every image that you are seeing over here and tell me what exactly is the use of all these instruments. Alright, so what is this instrument you can see over here? Instrument A, instrument B, instrument C, and instrument D. And what are all of them used for? Yes, budding FMG, you can use these mock tests for FMG too. Alright, very good Manoj. So the first picture that you can see over here, picture C that you can see over here is the Tuhi needle. This Tuhi needle is also commonly called as the epidural needle, correct? So how do you identify the Tuhi needle? First of all, there are 2 things that will help you in identification of the epidural needle or the Tuhi needle. The first one that you can see over here is the presence of this flange or the presence of this wing, okay? The second thing you can identify is alternate light and dark markings that you can see on the needle, okay? So this is how you identify the Tuhi needle or the epidural needle. Then what is the question that comes in the exam? Most of the times they tend to ask what is the last structure to be pierced before you reach the epidural space. So can you guys answer for me? Before you reach the epidural space, what is the last structure to be pierced? Alright. Now remember, many of you all ask me, ma'am, what is epidural anesthesia used for? What is epidural analgesia used for? Remember, the epidural space, you give local anesthetic in the space, and there are spinal nerves which are coming in that space. So whenever we give local anesthetic to those spinal nerves, your lower limbs and the area below the level of the umbilicus will become numb. Okay, so as a result of this, with your epidural anesthesia, you can maintain anesthesia for a longer period of time. Okay, now when we give spinal anesthesia, okay, when we give spinal anesthesia, the anesthesia lasts only for 1.5 to 2 hours. But in case of epidural, you can put a catheter. Can you see the catheter over here? This is a catheter. You can put a catheter in the epidural space, which is a loosely packed space, and you can maintain the anesthesia for almost how much ever time the surgery goes on. Okay, so even an 8 to 10 hour surgery, you can keep giving hourly boluses of local anesthetic through this epidural catheter, and it will keep bathing the spinal nerves in the epidural space. So you can basically maintain a long time regional anesthesia using epidural. So if they ask you in the exam, when do you use epidural anesthesia, just remember, whenever you want a long time surgery. Okay, so if your surgery is going to last for 7 hours, 8 hours, then we will use epidural anesthesia. Okay, alright. So Manoj, you are not correct. The last structure to be pierced before you reach the epidural space is nothing but ligamentum flavum. Okay, this is one of the questions that comes in the exam, and that's why I am specifically mentioning it for you guys. Ligamentum flavum is the last structure to be pierced when we reach the epidural space. Alright, okay. Now the next, can anyone tell me what is A? What is A? What is A? What is B? What is D? I think D you guys cannot see because I'm covering it up. But what form of anesthesia is D? Any idea, or should I give you all the answers? Okay, so remember, A is nothing but, yes, very good, A is our spinal needle. Can anyone tell me what is the other name of spinal needle? Other name of spinal needle is nothing but Quincke-Babcock needle. Okay, Quincke-Babcock needle. Now, how does a spinal needle look? How is it different from Toohey needle or epidural needle? You should know about it. So, can you see the spinal needle does not have a flange. It has a small hub over here. And this transparent hub is where you will get the CSF flowing. Okay, so you can see the backflow of CSF in this transparent hub. And then you have a thin needle over here. So, this is called as your spinal needle. Okay, now they will ask you in which space do you give spinal anesthesia. So very good, Neeraj has answered it correctly. You give spinal anesthesia in subarachnoid space. In subarachnoid space. Okay. If we ask you the same question, what is the last structure to be pierced before you reach the subarachnoid space? Can you tell me what would be the answer for that? Last structure to be pierced before you reach the subarachnoid space? Any idea? Okay, yes, absolutely correct, Manoj. So the last structure to be pierced is arachnoid meter. Okay, that's the last structure to be pierced before reaching the subarachnoid space. And remember, not just giving spinal anesthesia, this space is used for two things. One is to give spinal anesthesia, and the second is even when you do a lumbar puncture. Okay, lumbar puncture is basically for collecting your CSF. So for collecting CSF also you can use this space. Alright. Okay, now moving on to option B and D. Can you tell me what is there in B and D? Manoj, Neeraj, what is there in option B? What is there in option D? Okay, so Neeraj mentioned correctly before. He said that option D was nothing but caudal anesthesia. Okay, welcome to the class, Pancake, coming after very long. Hopefully you have had enough pancakes to last you for the class. Alright, so in option B, what are we having over here? This is nothing but a epidural set. Remember this. Okay, now what is an epidural set? So in epidural set, you have nothing but you have the Tuhi needle. This is the one that we already know about. Correct? Then we have the loss of resistance syringe. It is called as a LOR syringe or the loss of resistance syringe. It will help you in finding the epidural space. And then this, what you see over here, is nothing but your epidural catheter. This is your epidural catheter. Okay, so this epidural set basically helps you in putting the epidural catheter into the epidural space and maintaining anesthesia for a long period of time. And the last thing that you can see over here, which my head is covering, I'm just moving a little bit, is nothing but caudal anesthesia. Okay, so caudal anesthesia, what are we doing? We are basically putting a needle into the caudal space. What is the caudal space? Right at the upper level of the buttock of the child, we find a place over there and we put through the sacrococcygeal ligament, we put this needle and reach at the end of the spinal cord. So if this is my spinal cord, this is my cauda equina and filum terminal, then what am I doing? I am putting my needle here and it is reaching into the end of the spinal cord. Okay, so here I am going to give my local anesthetic and it is going to spread to these smaller spinal nerves which are at the filum terminal. So basically the lower lumbosacral nerves that are there, that will get covered by this. So if there is a small child, a child up to 8 years of age, I can give good pain relief using this caudal anesthesia in the lower limb, pain relief in the lower limb. Alright, so this is what we have in regards of regional anesthesia and what all can be asked in your exam. Alright, moving on to our next picture. Now can you guys identify what is A, what is B and what is C over here? What is A, B and C, guys? First of all, in A, what can you see is happening? They have basically, you can see that there is a pen like thing which is stimulating from outside and then you're putting a needle where the pen is stimulating. Okay, no, that is not central line. Alright, B, what you can see over here is ultrasonogram. Absolutely correct. So basically, all these three things are, B and C is the same. It is ultrasonography. Okay, so here you can see someone doing the ultrasonography in picture B, and in C you can see the different types of ultrasound probes. Okay, in A what you can see is nothing but the peripheral nerve locator. Peripheral nerve locator. Okay, so what do we see over here? Both of these instruments that are there, they are basically used for finding the nerves which you want to block, for locating the nerves that you want to block. So this is also a part of regional anesthesia. Now for example, what plexus of nerves is present over here? We all know that the brachial plexus is present over here in this area. Okay, the brachial plexus supplies your entire upper limb. So if I want to do any kind of upper limb surgery, suppose I want to do surgery of the forearm or surgery of the arm, in that case what I need to do? I need to give local anesthetic along the brachial plexus. So this entire brachial plexus nerves get completely numbed. So this entire hand becomes numb. It loses its motor and sensory power and I can operate on this hand without giving any other anesthesia to the patient. Okay, so this is a form of regional anesthesia. It is called as an upper limb block. So I don't need to give anything else to the patient. I just need to block the brachial plexus so that surgery on the hand can be carried out. Now, it's not that easy to find the brachial plexus. So you can't just take a needle and keep poking around over here and trying to find the plexus of nerves that is present in the neck. So what we do is either we use a peripheral nerve locator or a ultrasound to find it. Now, the gold standard method of finding these nerves is nothing but by ultrasound. Okay, so these are the three types of ultrasound probes. You have the linear probe. This is also called as the vascular probe. It helps you in finding superficial structures like nerves and blood vessels. Then you have the curvilinear probe that helps in finding deeper structures. And then you have the phased array probe, or this is used for carrying out a 2D echo. It is also called as a cardiac probe. So you should know about all the different types of probes that are present, okay? Because this can be asked in your exam. Ultrasound is one of the most upcoming modalities right now. It is being used in nearly all of the branches. So that is why they can ask you some questions on ultrasound for sure, okay? Now, the next that we have is the peripheral nerve locator. So how does the peripheral nerve locator work? So exactly like you can see in this picture, can you see over here, this pen like thing is stimulating the nerves from outside. So you give an electrical current. Here you can see the electrical current. Here you can see the electrical current. You give an electrical current and stimulate the brachial plexus nerves. The minute you reach somewhere near the brachial plexus nerves, the nerve gets stimulated and the hand starts moving, okay? So when you see this physical movement of the hand, you know that you have reached the brachial plexus. And at that time, this needle that is going inside, you can give local anesthetic to the brachial plexus that you have found using the peripheral nerve locator, okay? So that is how a peripheral nerve locator works. So if they ask you anything about regional anesthesia, these two slides will give you an entire idea. So you have your spinal needle, your epidural set, your caudal. These are parts of central neuraxial blockade, and this is part of peripheral blockade, your peripheral nerve locator and ultrasound machine. Now, can anyone tell me what are the drugs that we use? What is the main drugs that we use for central and peripheral nerve blockade? What drugs do we talk about whenever we talk about central and peripheral nerve blockade? Yes, not specifically lidocaine. You're half correct over here. So the drugs that we are bothered about are nothing but local anesthetic agents, okay? So local anesthetic agents like your lidocaine, bupivacaine, ropivacaine, prilocaine, all of them are the drugs that we use for regional anesthesia, okay? So all these are part of regional anesthesia. Okay, now moving on to our next slides for revision. So here we will be doing some drugs that are used in anesthesia. So we are going to be revising the pharmacology in anesthesia. Alright, so can anyone tell me what is the first drug that you guys can see over here? What is the first drug that you guys can see over here? Yes, absolutely correct. So in your exam, they may just give you a syringe of milky white drug, okay? So whenever they give you a syringe looking like it has milk in it, you should directly answer it as propofol, okay? Now, the questions that they will ask you about propofol are as follows. First one, you have to answer all of them. What is the class of drugs that it belongs to? Okay, what are the components of propofol? Then it is contraindicated in which patients, it is drug of choice in which surgery, and if you give it, what are the complications that you can see along with propofol? Any specific complications that you can see along with propofol? So batao, answers to all of them. What are the answers to all of them? What are the class of drugs that it belongs to? Yes, Mulai, you are absolutely correct. It is the drug of choice in daycare anesthesia. What is daycare anesthesia? Daycare anesthesia means patient, it's also called as short stay services, okay? Patient is getting admitted in the morning. he is getting operated and he is getting discharged on the same day. So you need an agent which acts for a very short period of time. So that is the agent that we use for day care anesthesia. Okay. Now, what is the class of drugs that it belongs to? General anesthetics? No. Anyone, what is the class of drugs that it belongs to? It is an IV anesthetic agent. It is an intravenous anesthetic agent. Okay. Alright. What are the components of propofol? This is one of the most commonly asked questions. So remember, propofol is made up of all the fats possible, correct? So it contains soybean oil, it contains egg yolk, it contains all of those things. Okay. And propofol is contraindicated in which condition? It is contraindicated in which condition? Yes, pancake, you are right. Eggs are used in pancakes as well. So you are correct. Eggs are also a component of propofol. Yes, very good. So if a patient is allergic to egg, okay, there are some proteins in egg like egg albumin, egg lecithin. If a patient is allergic to it, then you should not be giving propofol to that patient. Alright. Okay. The next thing that they ask is, now since it contains all these heavy fat like things, soybean oil, egg yolk, once I break open an ampule of propofol, within how many hours should I be using it? It should be used within dash number of hours. Once I break open a propofol ampule, it should be used within how many hours? Because if I keep the propofol ampule open and I keep it outside like that, then it will get infected. All the bacteria will grow on it because it's a very good culture medium. So in how many hours should I? No, not 48 hours. That's a lot of time. Okay, once I break open a propofol ampule, I have to use it within 6 hours. Okay. Alright. Now, what is the complication that you use that we see with propofol? There is something called as propofol infusion syndrome. Okay. So, if I give propofol continuously as an infusion for more than 48 hours, it can lead to metabolic dysfunction in the body, and that can lead to metabolic acidosis and death in the patient. That is called as propofol infusion syndrome. Okay. So this is all the questions that they ask about propofol in the exam. Now propofol is the most widely used IV anesthetic agent. So remember in the exam, if there is any question and you are not able to answer any question about pharmacology of anesthesia and you are like, I don't know kya hai, is it propofol, is it thiopentone, is it etomidate? So just go ahead and mark the answer as propofol. Okay, because it is one of the most widely used. तो अगर कुछ नहीं होगा आंसर तो propofol तो 100% होगा. Alright, okay, so moving on to our next set of questions now. So can anyone identify the second drug for me? Can anyone identify the second drug for me? Yes, very good, pancake. Propofol is also anti-emetic and anti-pruritic, so it prevents nausea, vomiting and itching. So second drug that we are seeing over here is nothing but ketamine. Okay, again same thing. First thing that they will ask is what is the class of drugs that it belongs to. Then where is ketamine preferred? When is ketamine contraindicated? What are the specific features that you see with ketamine? Batao. Yes, absolutely correct. So ketamine, if we go for the class of drugs, it is a NMDA receptor antagonist. It is NMDA receptor antagonist. Okay, now ketamine is preferred in which case? Ketamine is preferred in which case and it is contraindicated in which space? Yes, so remember ketamine is preferred whenever you have sepsis, whenever you have low blood pressure. So suppose you are having blood loss. So any condition in which you have low BP, in that you will prefer ketamine because ketamine maintains the hemodynamic parameters. Okay, it is also preferred in asthma. Remember, in asthma, ketamine causes maximum bronchodilation. That is why it is preferred in asthma. Okay. Now I know a few of you all cannot see what I'm writing over here, so I'll just move my head a little bit, or I'll become little short. Okay. Now ketamine is contraindicated whenever there is raised ICP or whenever there is raised intraocular pressure. Okay. So raised ICP or raised intraocular pressure. So whenever there is any kind of neurosurgery or there is glaucoma in which there is raised intraocular pressure, ketamine can further cause a raise in the ICP or the IOP. So we will prefer not to use ketamine in those cases. Okay. Any specific features about ketamine? Combat healer has mentioned. Dissociative anesthesia. Any other ones? What is dissociative anesthesia? So you feel like physically you are not a part of yourself, you're standing outside your body. That is the feeling that you get. Okay. And anything specific else that you see with ketamine? Anything else that you guys know of? Nystagmus, okay, yes, you get nystagmus, but more than that you get hallucinations with ketamine. Okay. And remember, ketamine is proemetic. So it causes more nausea and vomiting. Like how your propofol is antiemetic, ketamine is actually proemetic. Okay. Alright, moving on to our next class of drugs. So, can anyone identify this drug and then this drug? Okay, very good, Pancake. So this drug that you can see over here looks a lot like propofol, correct? This is also milky white in color if you see it properly, but it also comes in this plain form. So it may be either milky white in color or it may be in the plain liquid form. So this is nothing but etomidate. Okay. About etomidate, you need to know only 2-3 things. Now the first thing that you need to know is it is an IV anesthetic agent. Then what is it preferred in and what is it contraindicated in? Those are the only 2 things that you need to know about etomidate. Any idea? It is the preferred drug? Yes, very good, Mulai. So etomidate is always preferred in cardiac anesthesia. Okay. Remember, etomidate is the only anesthetic agent which will maintain your hemodynamics very well. It is very cardiostable. It will maintain your blood pressure and heart rate during induction of anesthesia. So in people who have poor cardiac functions, like in people who have had an MI, who are posted for bypass, who are posted for any other surgery, but they have a cardiac issue, you will prefer to use etomidate in them. Okay. So if they ask you in the exam what is the drug of choice for a patient who has had a myocardial infarction last week or someone who has a cardiac stenting done last week, in that case your answer would be etomidate. Okay. In which case is it contraindicated? Yes, very good. So etomidate causes suppression of the adrenal gland and it reduces the production of steroids. Okay, so there is reduced production of steroids. So as a result of this, ketamine is always contraindicated whenever you have adrenal gland suppression. If the patient is already suffering from adrenal gland suppression, for example, he is very sick, he is in the ICU for a long period of time, he has sepsis, already the adrenal gland is suppressed and the steroid production is low. So in that case, you will prefer to avoid etomidate. Alright. Okay, next question. What is this drug? What is the class of drugs that it belongs to? Sorry. So sorry. Yes, very good. So what is the drug that we are seeing over here? You can see it is made up, or it is powdery white in color and you have to reconstitute it using saline. Okay. So this is nothing but class of drug that thiopentone belongs to is barbiturates. Okay, now can you tell me thiopentone is preferred in which case and it is contraindicated in which case? Anyone? Very good, Pancake. So thiopentone is preferred in neurosurgery. Why? Along with maintaining a low intracranial pressure, it is also anti-epileptic in nature. It is also anti-epileptic in nature. Okay, so that's why we prefer it in neurosurgery. We also prefer it in induction of a patient who has hyperthyroidism. Okay, why hyperthyroidism? Because it prevents the peripheral conversion of T4 to T3. This is prevented by thiopentone. That's why we prefer it in hyperthyroidism. Okay, next one. It is contraindicated in which case? Very good. It is contraindicated in asthma and it is contraindicated in porphyrias. Contraindicated in asthma because it can cause. Why is it contraindicated in asthma? Because it can cause bronchoconstriction, and it is contraindicated in porphyrias because it causes acute intermittent porphyrias. Alright? Okay. Moving on to our next question. Identify these inhaled anesthetic agents and give me one important property of each and the MAC of each. Yes, it is used in eclampsia. So in eclampsia, basically you have seizures, right? In eclampsia, you have seizures, Pancake. That's why we prefer it in eclampsia. Okay, very good. So the first anesthetic agent that we have over here. The first anesthetic agent that we have over here is isoflurane. Correct? Alright, so can anyone give me the MAC of isoflurane? And then tell me isoflurane is preferred in which condition? And isoflurane, what are the drawbacks in isoflurane? Yellow is sevoflurane, absolutely correct. And blue is what? And red is what? All these are vaporizers which contain these individual anesthetic agents, correct? Blue is what? Blue is color of desi jersey. So blue has desflurane. And red has nothing but halothane. Barabar? Red has halothane. Okay, now tell me the MAC of each of these agents. Jaldi jaldi batao. I have told you all the MAC mnemonic. Everyone knows the MAC mnemonic. Okay, so first we have the MAC of isoflurane. So can you tell me what is the MAC of isoflurane? MAC of isoflurane, I and S लिखो पहले. I and S. Okay. यहाँ पे डॉट डाल दो isoflurane के I और S के बीच में and then you put a dash over here. So MAC of isoflurane is 1.4. Okay. Alright. In which case do I prefer isoflurane? Anyone? Isoflurane is preferred in 3 kinds of surgeries. Remember, we always prefer isoflurane in neurosurgery, in cardiac surgery, and in any surgery of the liver. So it is the most preferred agent of choice in any of these 3 surgeries: neurosurgery, cardiac surgery, liver surgery. So nearly in most of the surgeries we prefer isoflurane. Why? Because isoflurane maintains very good blood flow to all these important organs. So it will maintain good blood flow to the brain, to the heart, to the liver, to everything. That's why we prefer isoflurane as the inhalational agent of choice in these surgeries. Okay. Anyone, what is the drawback of isoflurane? Any contraindication or any drawback of isoflurane? Okay, so isoflurane, yes, very good. Side effect or drawback is it causes coronary steal phenomenon. Okay, what is coronary steal phenomenon? It is also called as reverse Robin Hood phenomenon. So you remember how Robin Hood used to take money from the rich and give it to the poor. So instead, if the reverse Robin Hood phenomenon or the coronary steal phenomenon says that you take money from the poor, you say poor is anyways going to remain poor. So you take money from the poor and you give it to the rich, saying rich को richer बनाओ और poor को poorer बनाओ. ऐसे ही दुनिया चलती है आजकल, है ना? So that is called as coronary steal or reverse Robin Hood phenomenon. So in coronary steal phenomenon, the blood flow from the ischemic area is taken instead and it is given to the richly perfused area. So you are making the poor is being made poorer and rich is being made richer. Coronary steal phenomenon. Alright. Now what is the MAC of sevoflurane? So I always say सिवाय हम दोनों के इस दुनिया में और कोई नहीं है. So that is the Leila Majnu dialogue, सिवाय हम दोनों के. So MAC is 2 of sevoflurane. Okay. इस दुनिया में और कोई नहीं है. Now when is sevoflurane preferred and when is it, what are the drawbacks of sevoflurane? When do you prefer sevoflurane? What are the drawbacks of sevoflurane? Anyone? See, in this one entire slide, you will be able to revise your entire inhalational agents. चलो बताओ बच्चों. Okay, so sevoflurane is always preferred whenever you have to do an inhalational induction. Okay, so this is used for inhalational induction, or if they ever ask you what is the agent of choice in pediatric patients, agent of choice in pediatric patients, you will answer it as sevoflurane. Okay, now in pediatric patients, how do you induce anesthesia? You can't take IV line in them, they will kick and hit you. So instead you hold a mask, tell them to smell sevoflurane. It's very nice and sweet smelling, and while smelling sevoflurane they go off to sleep. Once they go off to sleep, you put IV line in them. So that is called as inhalational induction. Okay, now sevoflurane is preferred for inhalational induction because it's very, very sweet smelling. That's why. Now what are the drawbacks of sevoflurane? Anyone? Yes, absolutely correct, Pancake. So sevoflurane can react with soda lime or carbon dioxide absorber and lead to the formation of compound A. Okay, so sevoflurane plus carbon dioxide absorber can lead to formation of compound A, and this compound A can damage the kidney. It is nephrotoxic in nature. Alright, next ये बताओ, what is the MAC of desflurane? Anyone, what is the MAC of desflurane? What is the MAC of desflurane? Where is desflurane preferred? Where is desflurane contraindicated? Okay, किसी को नहीं आता? Is there some problem with everyone's internet? Alright, so the MAC of desflurane is 6. How do we remember that? Remember, in a Desi family, in DESI, in a Desi family, we have 6 people. We have parents, we have grandparents, and we have 2 children. Okay, parents, grandparents, and 2 children. So in a Desi family, we have 6 people, correct? So MAC of desflurane is 6. Now, where is desflurane preferred? Desflurane is preferred in case of obese patients, and it is preferred in case of daycare anesthesia. Now remember, desflurane anesthesia जो होता है, it's very quick to act and very quick to finish. So if you want to do short surgeries or you want to do surgeries in fat patients in whom the inhalational agent can get stored in all their lipid stores, you will prefer to give desflurane. Okay, quick action and quick recovery. So it is preferred in case of obesity and daycare anesthesia. Now where is desflurane contraindicated? Desflurane has a very pungent odor, very pungent odor, very dirty smelling odor, and it can actually cause bronchospasm. So you want to avoid it in asthmatic patients, you want to avoid it in children in whom you want to do inhalational induction. Okay, last agent that we have is halothane. What is the MAC of halothane? Where is halothane preferred? Where is halothane contraindicated? चलो बताओ. Okay, Now halothane से याद रखो, halo is that round thing, circle thing that is there on the angel's head. Okay, so remember, where do angels stay? Angels have that halo on their head, and angels live in 7th heaven. Okay, just remember this, angels live in 7th heaven. So MAC of halothane is 0.7. Okay, now halothane is preferred. Okay, again you are not able to see, I'll move my chair a little bit. Alright, so halothane, remember, is a smooth muscle relaxant. Absolutely correct. So it is preferred whenever you want to dilate any smooth muscles. So if you want to dilate the uterus, if you want a uterine relaxant, like in abortions, okay, then if you want to dilate any smooth muscles of the bronchi, like in asthma, it can cause bronchodilation. So here we will prefer halothane, correct? So it is a smooth muscle relaxant being used for all this. Then what is the contraindication of halothane? Contraindication of halothane again is if you have postpartum hemorrhage, so you will prefer not to use halothane. And second is if you have halothane hepatitis, that is one of the side effects of halothane. Okay, in postpartum hemorrhage the uterus will relax and it will continue to bleed, so you will prefer not to use halothane because you want the uterus to contract and stop bleeding. And halothane hepatitis is nothing but on repeated exposure to anesthesia with halothane, there are antibodies formed against the liver and that can lead to liver failure. So that is called as halothane hepatitis. Okay, now what are the kind of questions that come in the exam? From this entire slide you will get simple questions like, what is the inhalational agent preferred in neurosurgery? So you will answer it as isoflurane. What is the inhalation agent preferred in asthma? Answer will be halothane. What is the inhalation agent preferred in daycare surgery? Desflurane. What is the inhalation agent that has a pungent odor? Answer will be desflurane. Okay. What is the inhalation agent that destroys the liver? So it will be halothane. So वैसे answers देने तुमको. Alright. Okay, so those are the kind of questions that will come and the answers that you need to give. Now, next class of drugs. Can you guys see this next class of drugs and tell me what they are and what do they do? Yes, pancake. As halothane dilates the uterus, relaxes the uterus, you can also carry out external and internal cephalic version in it. So what is the next class of drugs? All of you all can see. Rocuronium, okay. Rocuronium, vecuronium, and this one over here, which is written as Sucol, is nothing but succinylcholine. So what is this class of drugs that you see? Batao, what is it used for? Yes, these very good Anu. So these are nothing but muscle relaxants, or they are also called as neuromuscular blocking agent, NMBAs, neuromuscular blocking agent. Okay, now I am going to divide this into two parts. Can you tell me what will the division be into two different types of neuromuscular blocking agents? So here we have the depolarizing type of neuromuscular blocking agent, that is succinylcholine, and here we have the non-depolarizing type of agent, neuromuscular blocking agents, which is your vecuronium, rocuronium, atracurium, all of them. Okay, so now I'm going to ask you single question about all of them. So scoline is preferred in which case? It is contraindicated in which case? Before giving scoline, which serum electrolyte should you check? And action of scoline is terminated by what? Okay, so these are the four questions that you need to answer for me. Scoline related. Batao. Okay, very good. So scoline is preferred in rapid sequence induction. What is rapid sequence induction? If you have a patient in whom you have to quickly give anesthesia. So for example, patient has come for emergency surgery and patient has a blown up abdomen, like he's having obstruction or he's having perforation, you want to give anesthesia very quickly, and patient has high chances of aspiration pneumonia. Okay, so in that case, patient is not fasting enough, you will prefer to give succinylcholine for anesthesia. Why? Succinylcholine is rapidly acting, it acts within 30 to 40 seconds, and it is short acting. It acts for 9 to 14 minutes. Okay, so for rapid sequence induction, we prefer succinylcholine anesthesia. Alright, other than that, second thing is, whenever you have an anticipated difficult airway, so suppose there is a patient who is very obese, 150 kg, and you have to intubate the patient. Now you don't know whether you will be able to intubate the patient or not. So you are scared to give paralysis to the patient. If you paralyze the patient, patient cannot breathe on his own, and the patient is very, very fat. So you're scared, what should I do? What should I do? If I don't relax the patient, intubation will become difficult. If I relax the patient and I'm unable to intubate, the patient can die of hypoxia. So you are in a do or die situation. So there you can give succinylcholine. So by giving succinylcholine, what can you do? It is rapidly acting, it is short acting. So you can, even if you are not able to intubate the patient and you have given scoline to the patient, the scoline action will go away in 9 minutes and the patient will start breathing again. Okay. Alright, so in RSI and in anticipated difficult airway, we prefer to give short acting muscle relaxant like scoline. In which condition is scoline contraindicated? Any idea? Any idea in which condition is scoline contraindicated? Okay, so remember, scoline is contraindicated in burns. It is contraindicated in any muscular dystrophy. Any kind of muscular dystrophy, like Duchenne muscular dystrophy, Becker's muscular dystrophy, and it is contraindicated if the patient has had hyperkalemia. Okay, so the serum electrolyte abnormality that I was talking about is you should check the potassium levels before giving scoline to the patient. So if the potassium is high, if it is more than 5.5, you should avoid giving scoline, because scoline can cause increase in potassium levels. Okay, alright. Then action of scoline is terminated by an enzyme called as plasma cholinesterase or pseudocholinesterase. Plasma cholinesterase or pseudocholinesterase that is present in the serum. Alright. Okay. Now you have these non-depolarizing agents over here. You have vecuronium, rocuronium. So can you tell me what is the most preferred? The questions that they ask on this is most preferred. Most preferred non-depolarizing agent in cardiac surgery. Then, which is the shortest acting non-depolarizing agent? Which is the most rapidly acting non-depolarizing agent? Okay. Then, in liver and in kidney failure, which is the agent that we prefer? And how do we terminate the action of non-depolarizing agents? Give me the answer to all of these questions. Okay. No, shortest acting is not Gantacurium, shortest acting is Mivacurium. Overall, if they ask you shortest acting overall neuromuscular blocking agent, remember it will be scoline. Scoline acts only for 9 to 14 minutes. Okay. But if they ask you shortest acting non-depolarizing agent, then it will be Mivacurium. Okay. Yeah. Gantacurium, guys, is not even available. Alright. Yes, for cardiac surgery, we will prefer to use vecuronium. It is very cardiostable. It does not increase the blood pressure or the heart rate. Okay. Yeah. What is the most rapidly acting neuromuscular blocking agent? Rocket Singh. Rapidly acting neuromuscular blockade agent. You can remember it. It is as fast as a rocket. If they ask you overall what is most rapidly acting, remember it is succinylcholine. But only neuromuscular, the non-depolarizing agent, it will be rocuronium. Okay, rapidly acting will be rocuronium. Alright. And in case of liver and kidney failure, what is the agent that you will give? Anyone in case of liver or kidney failure, which is the non-depolarizing agent that you will prefer to give? Something that will undergo elimination on its own? You will prefer to give atracurium. Absolutely correct. Atracurium, because it undergoes Hoffman's elimination and degradation in the plasma on its own. Okay. And how do you terminate the action of non-depolarizing agent? You terminate the action of non-depolarizing agent by giving reversal agent. Okay. What is reversal agent? Reversal agent is a mixture of neostigmine plus glycopyrrolate. Neostigmine plus glycopyrrolate. Alright, so these are all the questions that they will ask about neuromuscular blocking agents or muscle relaxants. What is the next class of drugs that you guys can see over here? Yes, local anesthetic agents. Okay, so my favorite class of drugs, local anesthetic agents used for regional anesthesia. So they can be used either for spinal anesthesia, epidural anesthesia, they can be, that is the central neuraxial blockage, or they can be used for peripheral blockade if you want to block the individual nerves. So first agent that we have over here is lignocaine. As you guys can see, you have to tell me the duration of action of lignocaine. Second class of drugs that we have over here is bupivacaine. So again you have to tell me the duration of action of bupivacaine. And the third drug that we have over here is 20% intralipid. So we'll talk about that also later. So tell me the duration of action of lignocaine, duration of action of bupivacaine. Also, what is the side effect of bupivacaine? What is the side effect of lignocaine? What is the maximum dose of lignocaine? And what is the maximum dose of bupivacaine? Okay, now remember the class of drugs that lignocaine and bupivacaine belong to. Your local anesthetic are divided into two. You have esters and you have amides. Okay, in amides you will have an extra eye. Like lignocaine, see here it has two eyes, one eye here and one extra eye here. Bupivacaine has two eyes, one eye here and one extra eye here. Okay, so basically local anesthetics have two eyes in them. The amides have two eyes in them. The esters have only one eye. So your most commonly used local anesthetics are lignocaine, bupivacaine, ropivacaine, all of them. The less commonly used ones are procaine and benzocaine. All of those are all your single eye ones. They are esters. Okay, so the most commonly used is lignocaine and bupivacaine. You just need to tell me what is the duration of action of lignocaine, duration of action of bupivacaine. Batao. Okay, at least you can tell me intermediate action, long action. What is the action of lignocaine and bupivacaine? Okay, so remember lignocaine is intermediate acting. So it acts for about 30 to 45 minutes, and your bupivacaine is long acting, so it can act for 3 to 4 hours. Can anyone tell me what is the side effect with lignocaine? You can get something called as local anesthesia, systemic toxicity, correct? What is the specific side effect with bupivacaine? Why am I very scared about bupivacaine? Why am I scared about bupivacaine? Because it can act on the heart, okay? So it can act on the heart, it can cause cardiac toxicity, and it can lead to cardiac arrest. What is the maximum dose of lignocaine? What is the maximum dose of bupivacaine? What is the maximum dose of lignocaine? What is the maximum dose of bupivacaine? Yes, so it depends on whether you give lignocaine with adrenaline or without adrenaline. Okay, so remember, lignocaine plus adrenaline, maximum dose is 7 mg per kg, and lignocaine without adrenaline, maximum dose is 5 mg per kg. What is the maximum dose of bupivacaine? Maximum dose of bupivacaine is 2 mg per kg. Alright, now can you tell me what is this drug used for? 20% intralipid. What is it used for? What is 20% intralipid used for? Any idea? Okay, 20% intralipid is used in the case of local anesthesia systemic toxicity. Okay, so whenever you have LAST or local anesthesia systemic toxicity, if you give excessive local anesthetic agent or you directly give the entire dose of local anesthetic agent into the blood vessel, you can get LAST. So patient will present with tingling, numbness around the mouth, patient will present with seizures, arrhythmias, cardiac arrest, all of those things. In that case, we give 20% intralipid as the treatment of choice. Alright, okay. Moving on to our next set of pictures in discussion. So can you guys identify what are these? What are all of these that you can see? These are your cylinders, correct? These are your cylinders, not gas cylinders. These are your cylinders which store your anesthetic agents, okay? So they actually store your carrier gases, not anesthetic agents. I'm very sorry, they store your carrier gases, okay? Now, what are your carrier gases? Whenever you're giving anesthesia, you have to give the inhaled anesthetic agents like desflurane, sevoflurane, isoflurane. They are all present in the vapor form. So to carry these vapors, you require some carrier gases. So what are the common carrier gases that we use? We use oxygen, nitrous oxide, carbon dioxide. Carbon dioxide is not used. We use oxygen, nitrous oxide and air. These are the three commonly used carrier gases. They will carry the vapors of this inhaled anesthetic agents into the lungs of the patient. Okay. So from the color, can you identify this color? French blue color cylinder is carrying what carrier gas? This color cylinder is carrying what carrier gas? This color cylinder is carrying what carrier gas? Batao. Individually tell me, what are all these cylinders carrying? Which carrier gas are they carrying? Yes, so the French blue color cylinder contains nitrous oxide in it. Very good. Remember, nitrous oxide is also called as laughing gas. Okay. Now, can you tell me what is the pressure in this cylinder, in the French blue cylinder carrying nitrous oxide? Any idea? Cylinder pressure, if they ask you. So the cylinder pressure is around 760 psi. Psi is pound per square inch. Okay, yeah. Then your black body with white shoulder. Black body with white shoulder. Similar to the Unacademy t-shirt, black body with white shoulder is your oxygen cylinder. Okay, so remember, Unacademy is your oxygen for your preparation. So the pressure in oxygen cylinder is 1900 psi. Then this grey cylinder is carrying what? Any idea? And this one with alternate black and white stripes is carrying what? Grey cylinder does not have oxygen. Okay, grey cylinder has carbon dioxide in it. And this one, the alternate light and dark markings, alternate white and black markings contains air in it, medical air. Okay, now a few things that I want to ask you guys about nitrous oxide. So with nitrous oxide you get two important features. Can you tell me what are those two important features that we get? Just two very peculiar things that we get with nitrous oxide. So towards the end of surgery, when I switch off my nitrous oxide flow, what is the peculiar thing that I get? The nitrous oxide causes dilution of all the oxygen. So what is that condition called? Yes, that is called as diffusion hypoxia. Diffusion hypoxia, that is towards the end of surgery. Okay. Now, if I use nitrous oxide along with other inhaled anesthetic agents, then I have to use less quantity of the inhaled anesthetic agents because nitrous oxide has a MAC of its own. The MAC of nitrous oxide is 104. So basically, nitrous oxide reduces my requirement or usage of other inhaled anesthetic agents. So what is the name of that condition? Yes, that is called as second gas effect. That is called as second gas effect. Alright. Now, next, let's move on to our instruments that we use in anesthesia. So, can anyone tell me the full name of all these instruments? Okay guys, other than this, now you all should also be knowing the pin index system whenever we talk about cylinders. So I always remember it as AON, ion pin index system. Of air is 1,5, oxygen is 2,5 and nitrous oxide is 3,5. Okay, so that is the pin index system that you should remember. And other than the pin index system, you should also know the color of the pipelines. Okay, so here we have seen the color of the cylinders. You should also know the color of the pipelines. So I'll just write it over here because I have no space. But in pipeline, you have to tell me what is the color of air pipeline. You have to tell me what is the color of oxygen pipeline, color of nitrous oxide pipeline and color of vacuum pipeline. पहले ये बताओ, then we'll go to the LMAs. Okay, anyone color of the pipelines? Because this had come this time in NEET PG, not the color of the cylinders. They had asked color of the pipelines. So nitrous oxide color is same as that of the color of the cylinder. So that is again blue in color. Okay, color of the vacuum pipeline, any idea? Vacuum used for suction. It is yellow in color. Okay, color of oxygen pipeline. Now here the oxygen cylinder you can see is black and white, but the oxygen pipeline color is white. Okay, and color of the air pipeline is similar to that of the cylinder, alternate white and black stripes. Alright, okay, so these are color of all the pipelines. So you should know the color of all the cylinders, color of all the pipelines, and the pin index of all the cylinders. Alright? Okay. Alright, so moving on to our next part. So these are called as LMA or SAD. What is the full form of SAD? What is the full form of SAD? Anyone? Yes, LMA is laryngeal mask airway. SAD is also called as supraglottic airway device. Okay, now can you guys identify these LMAs or SADs for me? Which is 1, which is 2, which is 3, which is 4, which is 5, and which is 6? Batao. These are supraglottic airway devices, absolutely correct. Can you tell me which are individually all of these supraglottic LMA devices? Yes, so second one, very good, Anu, is LMA Supreme. Perfect. Any other one that you can identify between 1, 2, 3, 4, 5, 6? 3 is intubating LMA, very good. What is the other name of intubating LMA? It is also called as LMA fast track. Four is ProSeal. Excellent. Narmata Devi, very good. This is LMA ProSeal. Very good, Anu. One is LMA Classic. And any other LMAs that you guys can identify? Five and 6 is left. 5 is fully green LMA. Any idea? This is called as the Ambu LMA. And 6, what is peculiar about 6? See that there is no pilot inflation line, there is no pilot balloon over here like here. In all other LMAs is present. Very good, Anu. So 6 is iGel LMA. Alright, now you need to know the peculiar properties of each of these LMAs and you need to know the sizes of LMAs used. Okay, so if we talk about the sizes of LMAs, first of all you need to know the weight and the weight wise size. So in the smallest size human being, in a newborn who is less than 5 kg, we use size 1. Okay, then the next size that you need to remember is size 3, that is used in 3 likh do idhar hi, 330 to 50 kg person. And then you have size 4. Size 4 is seen in 50 to 70 kg person. Alright. So these are the 3 main sizes that you need to remember for regards to your LMA. Alright. Now with this, all the other LMAs that you can see, you are having 2 openings to it. Can you see? All the other LMAs, you can see that there are 2 openings. One is for your airway tube, this one, the bigger one, and the smaller one is for your gastric tube. Okay, again over here also you will have 2 openings. Here also you see you have 2 openings. This is airway tube, gastric tube. Here also airway tube, gastric tube. Here also airway tube, gastric tube. Okay, so all of these which have 2 openings are nothing but second generation LMA. The only one which has 1 opening over here, this is your first generation LMA. This is your first generation LMA or LMA Classic. So if in the exam you ever need to identify LMA Classic or first generation LMA, it's very easy. You can see that this is the cuff or the bowl of the LMA, and from there you just see one single tube coming out, and that is your first generation LMA, LMA Classic. Okay, so easy to identify LMA Classic. Now What about the other LMAs and what are the specific questions asked about them? So you have LMA Supreme, okay? You can see it is made up of a soft seal disposable material. It is disposable, it is single use in nature, and it has two openings, one for the airway and one for the gastric opening. And this thing is called as a bite block. So it helps in so that you do not clamp upon your LMA, okay? So this is your disposable LMA Supreme. Then this intubating LMA or LMA fast track helps you in intubating the patient. So first you put the LMA, it will have the steel big handle over here. First you put the LMA, then through the LMA you put the endotracheal tube. Then once the endotracheal tube is inside, you have intubated the patient, you just remove the LMA out. So you have intubated your patient, okay? So this is your intubating LMA or LMA fast track. Then next, LMA ProSeal. LMA ProSeal is something which is non-disposable. You can use it again and again. You can use it up to 40 times. And it is the most preferred LMA for daycare surgery. So this is the question they asked about LMA ProSeal. Most preferred LMA for daycare surgery, it is LMA ProSeal. Alright. Okay. Then you have this Ambu LMA. How to identify it? It will be fully green in color. So that is your Ambu LMA. And finally you have your iGel LMA. iGel LMA, how to identify? It does not have the cuff inflation line and the cuff balloon. So how do you inflate the cuff? Sorry. Alright, so how do you... The brightness of the screen is going. Alright. So how do you inflate the cuff of the LMA? So you inflate the cuff of the... You don't need to inflate the cuff of the iGel LMA at all. You just need to put it inside, and this cuff that is there, it will take the warmth of the throat and it will expand on its own and form a seal over the vocal cords, okay? So that is how you use your iGel LMA. So these are all our different types of LMAs. Specific questions asked about them. LMA Classic, first generation LMA. LMA Supreme, they don't ask much. About intubating LMA, they ask for which condition you use it. So in difficult airway, you can use this to intubate the patient. Then LMA ProSeal is the one that they tend to ask a lot, and it is preferred for daycare surgery. And then you have Ambu and iGel LMA. Alright. So with this, we finished the Anesthesia Revision Part 1. We'll be having the Revision Part 2 at 6:15 p.m. And in that we will be revising all your different types of laryngoscopes, different types of capnographs, different types of oxygen delivery devices, all that is left, okay? Remember, these two anesthesia revisions will cover almost 80% of anesthesia that you need to know for your exam point of view, all the important topics. So make sure that you attend these classes well and you have a good take home message from them. So I'm just, before quickly going to show you all the important things that we have seen till now. We've seen the different types of LMAs, we've seen the different types of cylinders and pipelines in anesthesia, local anesthetic drugs, muscle relaxants, inhaled anesthetic agents, then your IV induction agents, and your regional anesthesia instruments like USG, peripheral nerve locator, spinal epidural, and caudal anesthesia, central neuraxial blockade. Alright. So I hope that this class was useful to you guys. Please don't forget to leave a thumbs up at the end of it, and I will see you guys at 6:15. Till then, keep studying. Bye bye. Also guys, please make sure that you join this Telegram group, Let's Crack NEET PG. So this is where you will get the links to all the classes. Even the link to the 6:15 class will be shared on this Telegram group. So make sure that you join it. Alright.